presentation, we're going to be talking about mobility and how it relates to everything. So the objectives, we're going to want to understand mobility, what puts a patient at risk for altered mobility. We're going to want to identify negative consequences of altered mobility and look at the exemplars that are some common mobility disorders. And we're going to look at the nursing process with each of those exemplars and in general to look at how mobility affects us. So for our exemplars, we're discussing disuse syndrome, hip fractures, joint replacement, osteoarthritis, and osteoporosis. Make sure you do your quiz. Want to give y'all credit. Mobility is what you think it is. It's consisting of factors that facilitate or impair movement of the body. It's that purposeful physical movement, and that includes like the fine motor movement, like finger movement, that includes mobility. And it does require a lot of things working at the same time. We have to have synchronized efforts of the musculoskeletal system, the nervous system, and we need adequate perfusion and oxygenation. Next is impaired physical mobility. So that's where I just have limitations to my physical movement, but I'm not immobile. And then immobility. It's the inability to move. So immobile, can't move. This is a big concept. Not only is it interrelated to nearly every other concept you have, but it also has a lot of mental factors that go with it. It means the freedom and independence for your patients. A loss of mobility doesn't seem like a huge deal until you have to experience it. On a smaller scale, I feel like most of y'all have sprained your ankle, or some of y'all may have been in cast or wheelchairs or broken a bone. That made you immobile for a little bit. And think how you felt and how difficult it was to get around. Sometimes it makes you depressed because you don't want to go out because it is so difficult and you feel like a burden on people. And then if you had to be wheelchair bound or use an assistive device, it can be embarrassing. You sometimes don't want to do that. And honestly, even with the ADA requirements and it being addressed somewhat in America, you can't go some places in a wheelchair, and it's just how it is. And so physically and mentally, mobility has a big effect on these people. I kind of talked about this on the last slide, but why do we study mobility? Well, one, it affects everything, but our bodies are meant to be in motion. A body in motion stays in motion. So some aspects, like the American lifestyle, is more sedentary. That's having a negative impact on our mobility. And like I said earlier, it not only has a negative physical impact, but also there's negative mental impacts if a person is suffering from immobility. Think about some of the situations that lead to immobility. There are some that happen over time, and they're slow and progressive, but there's others that are fairly instant. Like if you have a spinal fracture that causes paralysis. Most of the time, that's not a progressive disease. That is an instant, an accident that caused that break. So that is life-altering in a moment. And just how it's difficult to learn how to walk when we're little, it's difficult to learn how to live a different way. Mobility is a big factor in how we live our daily lives, and when it's altered, it can negatively impact quite a bit. In case you haven't figured it out, nursing process isn't everything. So we're going to look at how the nursing process relates to mobility. So when you're assessing someone, either full head to toe or just assessing their mobility, you're going to want to ask about if they've had any falls, or injuries, if they have a family history of diseases that cause immobility, like osteoporosis or osteoarthritis, we're going to want to assess their pain because their pain could be musculoskeletal related and lead to them not wanting to move much, which leads to the joint getting stiff, and it can just snowball from there. So we want to assess their pain and do a detailed assessment on pain. What makes it worse? What makes it better? Does rest help? Does ice help? Heat, elevation? We're going to want to look at all that. And if they've had any previous injuries. When you're doing physical assessments, y'all have done range of motion. I saw like a third of y'all where you gas pedal and lift the feet up. That's looking at range of motion of the ankles. Personally, I can't do that. I shattered both ankles about 8 years ago in a car accident. So if you were just assessing my ankles and didn't know about my previous injuries, you might be concerned, like, oh no, she can't move her ankles. Like, this red flag's big deal. But we're going to ask my history, and you're going to find out that both my ankles were shattered, and this is just how they are. And then it's no longer concerning. So with history on any concept, but with specific to mobility today, it's really important to go into detail with your patient and ask these questions in a conversation and just figure out why things are going on. Then we get to the physical assessment. So this is where you're going to do the range of motion that Ms. Mathis taught you. We're going to talk about their gait. We might ask them to walk. We might just observe them walking to the restroom or into the office room, or we might just observe. We're going to look at how they're bearing their weight, which also kind of relates to gait. But do they limp? Do they lean to one side when they walk? And we're going to ask, like we did with the history, have they had an injury that led to them their gait being a little off? And then also we're going to look for visible deformities. If your arm is stuck like this, that's a mobility issue. There may not be a visible deformity, but if also an acute thing, if their arm is hanging off, like broken radial ulnar, and their arm's just kind of swinging down here, that's a visible deformity that's going to lead to a musculoskeletal issue. Hopefully an acute one we can fix with surgery, but sometimes it is the obvious thing. So then we're going to get to analysis, and that's where you take all that data you gathered and assessment and look at some other labs and diagnostic tests. Some diagnostic exams that you will see in relation to mobility are x-rays, CTs, MRIs, and bone density scans. Another thing to be aware of, and it's not really a diagnostic exam, but this was the best place it fit, is physical therapy and occupational therapy evaluations. Those guys are pros at what they do. Mobility is their thing. So if they say someone has weakness, or they might be able to offer a cause, maybe not the cause, because that's going to be the doctor's role, but they can offer a plan of care to help restore the mobility for that patient. And when you're assessing, you can find out if they've done PT or OT before. And just fun little factoids. Physical therapy is more gross motor activity, walking, driving, stairs, where occupational therapy is more the fine motor activities such as writing, eating. That's the best way to think about it. Physical therapy is gross motor, occupational therapy is fine motor. And then the plan. Our plan is focused on maintaining the patient's mobility. If possible, we want their mobility to improve, but with some diagnosis, that's not possible. So we just don't want it to get worse, is the goal. If they have gotten worse temporarily due to an acute issue, we want to get them back to their baseline. And to implement, we're going to collaborate with PT and OT. Those guys are pros at what they do, and they, like I said earlier, their focus is mobility. So they're going to be able to help us with the plan of care for this patient. And it's really also important to consider pain management. I don't know if anyone listening to this has done physical therapy before. It hurts. Personally, I didn't want to do it because it hurt. I would have much rather been sad and depressed in my hospital bed than go to PT in my wheelchair where it hurt. So, pain management is important. We want to pre medicate when appropriate our patients to help them be able to do the get the most out of their PT sessions. And then we evaluate, were the goals met? Did the patient return to baseline? Do we need to reevaluate our goals or replan? Now that you know kind of how to apply the nursing process just to mobility in general, we're going to focus on the exemplars. First one we're going to talk about is disuse syndrome, and it is really short and a very simple syndrome. Disuse syndrome is where the body is deconditioned and it's kind of a loss of physical fitness. It has adverse effects on the body tissue and functions, and it's due to sedentary lifestyle and inactivity. Basically, disuse syndrome, if you don't use it, you lose it. So, if I don't use my muscles, then I lose them. Kind of think like the big bodybuilders, when they quit and retire, their muscle mass drastically shrinks because they're no longer at the gym for hours a day. Some identifying characteristics of it are cardiovascular vulnerability, obesity, musculoskeletal fragility, depression, and premature aging. Disuse syndrome, as I said, is pretty plain and simple. If you don't use it, you lose it. Now we're going to talk about hip fractures. So hip fractures obviously happen in the hip joint, but there's a few different locations that the fracture can actually happen. So if you remember, your hip joint's kind of like this big bowl, and your femur is a ball that sits in it, and it's got the femoral neck and then the rest of your femur. So all these fractures happen somewhere on the femoral head or the neck. Some of them happen on the greater trochanter. So intercapsular fracture, so those happen within the cup. Then they can happen on the femoral neck too. So these fractures are common with osteoporosis and minor trauma. So if it's a capital fracture, it's on the head of the femur. If it's a subcapital, it's just below the head of the femur. And if it's a transcervical fracture, it's on the neck of the femur. And then there's extracapsular fractures, which occur outside this capsule. And these fractures are usually caused by severe direct trauma or a fall. This image, in case my hands didn't make sense to you, this image also shows you where these fractures can happen. Another example of a intertrochanter fracture, actually that was a different one, but the greater trochanter can actually break off, and that is still a hip fracture because it's up near that hip capsule. But just kind of look at this if you're a visual person, and maybe it'll help you understand where the fractures are happening. So, risk factors for hip fracture. So, being mobile, completely mobile, and having normal strength, and being completely immobile can put you at risk. So pretty much you're at risk for a hip fracture if you can move or you can't move. Just depends on what's going on. If you have chronic health problems, you're at increased risk. If you are 65 or older, if you have environmental hazards in your life, if you're a woman This is due to osteoporosis and being postmenopausal, if you have a trauma, and if you have multiple medication usage. So what are we going to assess in these patients? So there's a few slides on this because there's a lot we're going to be looking at. We're definitely going to be looking at their past health history. Have they had injuries? Have they had any bone diseases? Have they been immobile for a while? Do they have osteopenia or osteoporosis? So that increases their risk. We're going to look at their medications because the use of corticosteroids can lead to osteoporotic fractures. And some meds impair the absorption of vitamin D and calcium, which can lead to weak bones, which can lead to fracture. And then also, we're going to want to know what previous surgeries they've had. Then we're going to do a complete head to toe. What we're going to be looking at is deformity or unnatural position of that limb. So if they say their right hip hurts, we're going to focus on their right limb. Is there any edema or ecchymosis? Is there muscle spasm? Do they have tenderness and pain? Have they lost function at the site or below it? And do they have any numbness and tingling, maybe a loss of the distal pulses? Some other things you might see are pallor and cool skin distal to the injury. Their skin temperature is going to be low. We just talked about that. If all that's impaired, we also expect their cap refill to be slowed. They might have absent sensation or decreased sensation, or they might have hypersensation. So basically, if they're underfeeling or overfeeling, we're concerned. And they're going to have some muscle weakness. So where the fracture is changes how we assess them or what we assess. So if it's in the femoral neck, the leg is shortened, adducted, and externally rotated. So if this is feet, my toes, my legs are going to be adducted so they're together, but also externally rotated. So my foot's going to be kind of pointing out. The patient's going to report pain in the hip, groin, or in the medial side of the knee, so the inner side of the knee. And when they move their leg, their pain skyrockets. So movement means pain. So if the fracture is impacted intracapsular femoral neck, that's moderate discomfort. If the fracture is extracapsular, then, or it's a trochanteric fracture, the extremity is shortened, it's externally rotated to a greater degree, so it's way out there, and muscle spasms are gonna prevent positioning of the extremity. So even if we try to move it back, it's gonna spasm out, or the muscle is going to be so tight we can't move it. And this is confirmed by x-ray. All these are confirmed by x-ray because although we can figure out kind of what's going on, we need x-ray to confirm so we can make a sound plan of care for the patient. We're going to look also, like I said, medications, if they're on estrogen or calcium supplements. What was their normal activity? Did they have loss of motion and weakness, or have they since the injury? And they are going to have sudden and severe pain and numbing, tingling, and loss of sensation. Neurovascular, super important because y'all learned about perfusion earlier this week. And perfusion, big deal. So we're going to want to check because we don't want their hip injury to cause injury to tissue below it due to a lack of blood supply. So we're going to want to maintain or keep assessing their color, the temperature, distal to the injury. Cap refill, make sure there's pedal pulses still, and monitor for edema because if it swells up, then that puts pressure on the vascular system and makes it more difficult for blood and nutrients to get through. We're also going to look at if they have sensation, motor function, and what causes pain or makes it better. So what's our plan? Patient comes in with a hip fracture, we got to have a plan. We want physiologic healing with no more complications. That's optimal. We want to make sure that we try and get them back to their baseline with optimal rehab. We want pain relief. We don't want them hurting. We do not want complications, and we don't want to continue loss of function because of this fracture. So there are two options of treatment. A closed reduction, which is Buck's traction, and an open reduction, which is surgical repair. Closed reduction is only good for 24 to 48 hours. It's a temporary fix. And what it is traction is manually applied to the bone to help restore their position and align them. It is non-surgical, but as I said, it's only a temporary solution. Then there's open reduction, which is a correction of the bone through surgery. It includes internal fixation with wires, screws, pins, and rods, maybe even nails. So Buck's traction. This is going to be your closed reduction method. And as I said, it's good for a maximum of 24 to 48 hours. Its goal is to immobilize the leg and manage the muscle spasms. So what are you going to do as a nurse? You are going to inspect all the skin that's exposed regularly. You're going to assess those bony prominences because we don't need skin breakdown to occur. You're going to maintain extremity alignment. So what that means is once we have the Buck's traction set up, we want their legs straight, not the injured one getting a little wonky and rotating out. That defeats the purpose. We're going to want to monitor nausea and vomiting, and we're going to monitor and maintain the weights that are placed at the end of the Buck's traction. This is what Buck's traction looks like. So it is that white thing on their calf, Velcro's on, and it's got like a boot that keeps their foot elevated so it doesn't have foot drop. And it is set up with a pulley system to weights. Big key thing. The weights should never rest on the ground. They need to be off the ground. So this is one of the very few times in nursing that it's okay to have the bed not at the lowest position, because sometimes it's the only way we get the weights off the ground. So weights, never sitting on the ground, because then it's not doing anything. This is what the weights do, is they pull that bone straight and pull the foot straight so it's properly aligned and just offer resistance. Like we said, or I said earlier, this is a temporary solution, but it does help with those muscle spasms. So just using that critical thinking and judgment, what are some reasons that y'all think we might go for Buck's traction instead of just taking a patient to surgery and fixing it? Well, what if the patient isn't medically stable for surgery? Hip surgery is a big surgery. So a lot of times you have those dramatic as seen on TVs, or you've heard on the news, or maybe even had a family member that's fallen and had been down for an unknown amount of time. So our first priority is going to be the medical resolution, like fixing their fluid and electrolytes, making sure they can survive the surgery before we take them to surgery. So that's where Buck's traction, or closed reduction, offers us a temporary solution that gives us time to help with the pain, but also resolve some medical issues that could be going on. Then the other way to help fix a hip fracture is an open reduction and internal fixation. This is a surgery. We're going to need early immobilization, but it does decrease the risk of major complications. On a side note, not all of them though, because there are risk and complications with every surgery. But this does also include internal fixation with wires, screws, pins, plates, rods, nails, whatever they need to do to get the bone back together. One of the bigger risks with this is use of anesthesia. Like we said, these patients are generally older, so anesthesia can have a lot of negative effects on them. But if we are doing open reduction, we're going to have to take care of our patient pre-op and post-op. So pre-op, we're going to want to make sure that we maintain the traction. They might get put on Buck's traction even if they're going to surgery the next day because we want to align the bone. Some patients will end up going straight to OR. Depends on where they are, the situation, all that jazz that goes with planning and getting a patient into surgery. We're going to want to get them pain control though. Some analgesics, muscle relaxants. We're going to want them in a comfortable position, yet one that maintains the alignment of their leg. And we're going to implement safety measures. So bed in the lowest position, unless it puts the weights on the ground. Rails up, all their possessions near them so they're not trying to reach over and grab something or answer the phone. We're going to want to do some constant neurovascular assessments because we want to make sure that tissue below the injury doesn't get more damage, or hopefully any damage. And we're going to want to be teaching them. So when they come out of surgery, we do get them up very quickly now. Previous times, they used to get to stay in bed for a few days. We get them up the day of surgery most of the time. But we're going to want to teach them how to exercise their unaffected legs and arms because the other three extremities are going to have to pick up the slack for that one leg while it's healing. These patients are going to come with the overhead trapeze bar, and that is just, it's a trapeze bar that goes over their head and it helps them pull up in bed. And we're going to want to make sure that they don't have or educate them on postoperative care such as DVT and infection control. Then we do get to postoperative care. So they've had their surgery. They now have a nice incision on their affected hip, and we are taking care of them after surgery. We're going to want to monitor their vitals and their neuroassessment because we still don't want tissue damage below the injury. We're going to monitor intake and output. We want them to do respiratory activities and symptom spirometry. We don't want to add complications to their hip fracture by having atelectasis occur. Again, on pain control, we want their pain controlled so we can start doing physical therapy. We're going to want to do some incision care, and we're going to want to check and maintain for constipation and possibly medicate to prevent it because this patient is moving less, plus they're taking opioids and analgesics. So it is important that when turning this patient, you use the abductor pillow. So if you remember abduction, that's taken apart. And this pillow is a little, not little, it's about the length of to the groin to some patients' knees, some of them's mid-calf, depending on how short they are. And it's a triangle. And it's got little grooves on the side and for their legs, and it Velcros on. We use this when we are turning this patient because what we don't want is them to abduct their legs and capsule the femoral head and pull this femoral head out of the capsule that they just fixed. So we want to keep their leg abducted. That way there's no extra pressure in the hip joint. So we're going to talk health promotion with these patients. Hopefully before injury, we're going to teach the public about safety precautions. Rugs are huge fall hazards. We want appropriate lighting, safety lectures this week. We want to implement those measures to help keep the patient safe and prevent the injuries. We're going to advocate for our patients. So personal actions the patient can take. while they're in the hospital. Use the call light. Don't get up out of bed by yourself. Um, when they're at home, they can ask for help to get up, or they can use appropriate safety handrails and shower accessories to help them and not fall. We're going to encourage moderate exercise to keep the muscle strength and balance. And we're going to encourage calcium and vitamin D intake to help strengthen their bones. When a patient has a fall from a hip injury or a hip fracture, it's sad news, but a lot of times, depending on their age, they die within a year. And it's due to some physical complications from the surgery, but also mental complications. You lose a lot of freedom after you have a hip fracture. But we try to avoid that. We want to focus on short-term goals. We want them to not be dependent and go back to their independent life and their ADLs. But we also want to preserve their strength and increase their strength and endurance. Then our long-term goals is we want to prevent problems associated with the injury, like mobility issues, immobility, pain, and muscle spasm. Possible complications from a hip fracture. A patient can get a fat embolism, a DVT, compartment syndrome, and pressure ulcers. So inside our long bones is fat tissue. When you fracture a long bone, it is possible that the fat inside the bone gets into the vascular system. If that occurs, it can also travel to the heart and the lungs and cause a fat embolism. These are deadly. But it's essentially another form. Let's not do that route. Fat embolism. So if fat gets in the bloodstream, it cannot fit through some of our vasculature, get stuck. When that occurs in the heart or the lungs, it is deadly. Deep vein thrombosis, or DVT, that is a blood clot in a deep vein. These patients are increased risk because they're not moving their legs as much as they were. So that's why we put on TEDs and SEDs to increase circulation to the legs. But if that blood clot travels, not only can it occlude the tissue below the clot, but it can also travel up to the heart and lungs and cause severe injury or death. Compartment syndrome. So our skin can only stretch so much. If we have a vascular bleed or a bleed, or if the patient's in a cast, that's something else that's common with. But if I'm bleeding into my skin, eventually my skin's going to stretch so much that it's just out of space, but also it's going to start compressing my internal vasculature and eventually squeeze it off to where I'm not getting blood flow below the point of tension. So it damages any tissue below the point of the compartment. And then pressure ulcers. Everyone's at risk for pressure ulcers, but when they're immobile and not moving as much, especially after a hip surgery where we have to keep them in a certain position, they're at increased risk for pressure ulcers, which we don't want. They're expensive and painful, and we just want to avoid them. Next, we're going to be talking about joint replacements. So, what joints can be replaced? Your hip, your knee, your shoulder, and surprisingly, your elbow, ankle, and wrist. We're focusing on knee and hip because those are the big common ones. But I learned that elbow and ankle and wrist can be replaced. It takes certain doctors and specialties, so we're not even going to talk about them. But just for your own knowledge, know they can be replaced. So when looking at joint replacement, we've already talked about what you're going to assess. So if your patient has had a hip replacement on their right side, we're going to focus on the incision, but we're also going to make sure that they still are perfusing and receiving adequate nervous and perfusion below the site of the injury. So big points with hip replacements are the position. We want it abducted, neutrally rotated, and limited flexion. We don't want any pressure on the heel, but big thing, the leg, the affected leg, so for example, we'll say the right leg, should never cross the center of the client's body while they're sitting, and nor turn inward when the client is in a supine position. So no more crossing their legs. We don't want that to cross the center of their body. Just like when I talked about hip fracture, where we don't want to mess with the capsule and the femoral head. When they've had a hip replacement, it actually can pop out. So if we cross our leg, it's gonna put some pressure on it and possibly pop it out. So we don't cross our legs, and we put their legs in a neutral position. We don't also like rotating it dramatically also. Same as with a hip replacement. If the patient has a total knee replacement, not only are we going to be assessing the knee, but also below to make sure it maintains vasculature and we don't kill their foot or the tissue below it. These patients are going to be on continuous passive motion. That is a machine. It hooks up to their knee and it makes the knee move constantly. It's called passive because it's not them doing the motion, and it's continuous. It's going to start with slow movements and little movements and work its way up to the full 90 degrees of flexion and full extension by discharge. So we're going to start slow, move big. But this is continuous, and you're just going to follow your physician's orders on this and maintain it being placed and placed correctly. With joint replacements, what's your job? So you as the nurse are going to need to be focused on infection prevention, wash your hands, providing wound care, and on infection prevention, administer the antibiotics as ordered. On wound care, we are going to be washing our hands before we do wound care, following doctor's orders on wound care. And just a note on that, I believe I said in a previous lecture, but just to reinforce, you will not be removing the dressing the first time. That will be the surgeon. After that, you'll follow wound care orders. We're going to get these patients up very rapidly, so PT needs to be involved in their care. And then we're going to discuss home safety. We want to make sure they have well-lit halls and no throw rugs and rails in their shower, just things like that to help promote safety. Next, we are going to be talking about osteoarthritis. The rest of the slideshow, I'm probably going to switch to audio. My tiny human is demanding to be held, and I don't want her distracting y'all because she is pretty adorable. But now we're going to focus on osteoarthritis. So this is the most common arthritis type. It is a progressive loss of cartilage. With that progressive loss of cartilage, there is joint pain, loss of function, and it is a progressive disease. So what happens is this destruction, it's being destroyed faster than it can rebuild. So this joint deterioration can lead to pain, immobility, muscle spasms, inflammation, and osteophytes, which are those bone spurs. So it's still trying to grow, but it's just not going fast enough. Also, with the cartilage disintegrating, the bone and the cartilage kind of float into the joint capsule, causing that crepitus sound. That's that kind of like popping, is a little haunted housey sound you might hear sometimes when people pop their joints or they start moving a stiff joint. So you are going to assess their history. These patients most likely are going to be older than 60. We're going to look at their physical assessment and how it's going to manifest. They're going to have joint pain and stiffness, but it's going to get better with rest or inactivity. They might have that crepitus. They might have Herbin's nodes or Bouchard's nodes. These are both nodules that build up on the fingers. The Herbin's are on distal interphalangeal joints, and the Bouchards are on proximal interphalangeal joints. So both nodules build up on the hands. With their pain, if it's vertebral issues, it could be radiating, especially if it's a cervical or lumbar compression, because the nerve roots are getting pinched. And they might have some atrophy of skeletal muscle because they're not going to be moving what hurts as much. So if you don't use it, you lose it. So they might start losing some skeletal muscles in the area that is affected with the arthritis. So psychosocial, this pain may cause some depression and anxiety. If this person was a runner and suddenly they can't do this activity they enjoyed so much anymore because of pain, it could lead to depression and anxiety. So labs, we're going to look at the ESR and the CRP. The CRP is an indicator of inflammation. If you have a positive CRP, that means that there's inflammation somewhere in the body. We might look at x-rays, MRIs, and CT too, just to see the extent of damage. So how do we treat it? Well, this patient's going to be on drug therapy. They're going to have some rest and immobilization, which we don't want to do for too long, but we do want to allow them to be as pain-free as possible. We're going to work on positioning. We might do heat or cool therapy. We're going to get them to get some weight control. If it's their knees where the arthritis is happening and they're obese, getting some weight off may help relieve some of that pressure. And we're also going to look at some integrative therapies like glucosamine and clonidogrel. These are the medications we may give. So they may get some Tylenol. They may take some NSAIDs like Celebrex or naproxen or ibuprofen. Those are non-steroid anti-inflammatories, so the goal of those is to reduce inflammation, which would reduce pain. We might look at topical analgesics like Aspartame or Caspin, and that's going to be to help relieve the pain at the site. Over the counter, the doctor may prescribe or order glucosamine. This helps rebuild the cartilage, reduce inflammation, and when it's taken with clonidrin, it can lead to less pain. But be aware of a shellfish allergy with this med. And we might, if the pain is bad enough, the physician might even do joint injections with glucocorticosteroids. This is going to treat the inflammation and replace the hydrolytic lost with the inflammation. So it's just going to replace the aspect that's lost due to the inflammation. But we want to make sure that the patient doesn't have bird, feather, or egg allergies. Then there is surgical management. So there's total joint arthroplasty. This is going to be not a joint replacement, but it's where they place like the ceramic or metal joint capsule in so the bone's not rubbing on bone. Total joint replacement, like we talked about earlier, they replace the whole joint. The arthroscopy, that's a little bit, it's less invasive, it's a little incision. Most of the time when they go in with this, they're just looking to see the damage, but they may be able to repair some small deformities. And the osteotomy, that's where they go in and cut some of the bone out. Like if this person has grown bone spurs, we would go in and take some of them out, hopefully to relieve some of the pain. The last exemplar we're going to talk about today is osteoporosis. So this is a bone disease. Osteoarthritis is a degeneration of the joint leading to bone on bone. Osteoporosis is a progressive metabolic bone disease where the bone becomes low in mass, porous, it structurally becomes weak, and it leads to bone or fragile bones. So your peak bone mass is achieved before age 20. This is hereditary, nutrition, exercise, and hormone related. So there's a lot of aspects at play related to your peak bone mass. And bone loss after your midlife is inevitable, but the rate depends on a lot of hereditary, nutrition, factors like that. So these bones, and just so you know how dramatic this disease can be, sometimes these bones just break with simple tasks like bumping a table or any mechanical stress. Hereditary is normally the main cause, but menopause, nutrition, there's a lot of factors at play. But think of it in simplistic terms, basically the bone is breaking down faster than it can be replaced. Osteoporosis is significantly more common in women than men, and there's a lot of reasons for that. So women generally have a lower calcium intake. Overall, we have less of a bone mass because we have a smaller frame. We're smaller than men generally to begin with, so there's just less there. Bone reabsorption begins earlier and accelerates after menopause. So this is where hormones come into play. Again, hormones with pregnancy and breastfeeding. They deplete a woman's skeletal reserve of calcium. So babies kind of take everything from you, even your reserves of calcium. And the longevity increases the likelihood. So basically, because women live longer than men, we're more likely to get osteoporosis. So in osteoporosis, like I said at the very beginning, the bone reabsorption, so the breakdown, exceeds the deposits. So it's breaking down faster than it can be replaced. This is most common in spine, hips, and the wrist. In normal, the bone depletes as fast as it's replaced, so our bone mass stays the same. But once we start losing faster than we can rebuild, our bones become weaker and they can spontaneously fracture from minimal traumas, like a simple fall that could lead to a broken hip, like we talked about earlier. Osteoporosis is one of the causes. Wedging and fractures of the vertebrae produce a gradual loss of height. So as the vertebral column kind of just starts to collapse down because it's lost its support, it can lead to kyphosis or Dwagger's hump. We've all seen this. It's just it's a hunchback. And usually the first signs of osteoporosis are back pain and silent and spontaneous fractures. That's why it's called the silent disease, because back pain, I don't know about y'all, but anytime my back hurts, I just write it off as I slept wrong or I've been standing too long. It's not something I really immediately think I need treatment for. And then by the time we have spontaneous fractures by bumping into the table or tripping, it's progressed pretty far. So what are some risk factors of osteoporosis? Being female, being older, having a low body weight. It's not necessarily that obesity isn't a risk factor, but low body weight will generally indicate a nutrition gap. Having white or Asian ethnicity, family history of osteoporosis, early menopause, excessive alcohol, cigarettes, having a sedentary lifestyle, having an insufficient calcium intake, or long-term use of some meds like corticosteroids, thyroid replacement, and anti-seizure meds. And in men, low testosterone levels can cause or put you at increased risk. So there are some diseases that just put a person at increased risk. If they have one of these diseases, we're going to be watching for osteoporosis also. Intestinal malabsorption, some kidney disease, RA, hyperthyroidism, chronic alcoholism, cirrhosis of the liver, diabetes, and hypogonadism. So doesn't necessarily mean they're going to have osteoporosis, but if the patient is diagnosed with one of these diseases, we're going to be watching out for signs and symptoms of osteoporosis. So, what are the signs and symptoms? Like I said a few slides ago, this is known as the silent disease because there's not really any symptoms. The first sign is back pain and spontaneous fractures. What we may see, though, is a patient that comes in with sudden strains, fractures, back pain, loss of height, and spinal deformities. These spinal deformities are caused by the compression of vertebrae, so there's spinal deformities and loss of height with that one. As I said earlier, back pain is one of the big signs, but a lot of time it's ignored because we just kind of write it off. When I say fractures, also know that these bones that can become so weak that a sudden sharp bump or fall can lead to a pretty dramatic fracture. Kind of like how we talked about hip fractures earlier, a patient with osteoporosis that's progressed enough, bumping into a table with their hip could lead to a hip fracture. So what are we going to assess? Like we've said, it goes unnoticed a lot of times until it's almost too late. We're going to do a history and a physical exam and also look at a family history. We're going to do a bone density, a bone mineral density scan. They might do ultrasounds, and they might do a dual energy x-ray. Really, when we do our history and physical, they might do some blood work too. We're going to be looking at calcium, phosphorus, and phosphate, just to see what's going on with their levels. That all sounds kind of bleak, but how do we treat it? So we are really going to focus on proper nutrition, calcium intake, exercise, preventing fractures, and medications. By taking more calcium, it will stop future loss or slow it down, but it's not going to form any new growth or development. This is just a quick note of foods that are high in calcium. NCLEX likes to ask these, so just be aware of some of these foods that are high in calcium. More treatment. So with exercise, we want to focus on muscle strength and coordination and balance. We do not want these patients doing high impact activities because it could lead to fractures. So we want them doing weight bearing activities, walking, stair climbing, dancing, but not too high impact because we don't want them to risk a fracture. Supplemental vitamin D may be recommended, depends on what other disease processes the patient has going on. And like always, we want our patients to quit smoking. And if they're drinking, we want them to cut down on it to prevent losing more bone mass. So what medications might be prescribed? There is a lot in the notes section on this one, but we might be promoting calcium and vitamin D. The bisphosphonates are going to help bone reabsorption, and it's got a list of some common ones. We might be giving some estrogen. Like I said, menopause can lead to osteoporosis, so we might be helping out by giving the women estrogen. And for thyroid concerns, we might be giving teriparatide, and that's going to help with those patients that have had hyperthyroidism. The notes section on this slide has a lot of information that I will allow y'all to read. I would recommend maybe writing some of these down because it's a lot of meds and it's easy to confuse meds. But I really hope this kind of helped y'all understand mobility and how it's related with nearly everything. Please don't hesitate to ask me questions, and I hope y'all have a good afternoon.